Let me tell you about a patient. I'll call her Margaret. She was 68 years old, sharp as a tack, did the crossword every morning, remembered every birthday in her family without checking a calendar. Her daughter described her as the human Google of our household. Then, about 18 months after her doctor added a new prescription to her daily routine, her daughter called me in tears. Margaret couldn't remember what she'd eaten for breakfast. She was getting confused driving home from the grocery store she'd visited every week for 20 years. She repeated the same questions 3 times in a single conversation. Her neurologist suspected early Alzheimer's. Her family was devastated. But here's the thing nobody told them, and this is what I need you to hear right now. Margaret's dementia wasn't Alzheimer's at all. It was her medicine cabinet. When we systematically reviewed her medications and made strategic changes with her physician's guidance, Margaret started coming back. Within 4 months, she was doing the crossword again. This is not a miracle story. This is preventable medicine. And today, I'm going to walk you through the 9 most common medications that could be quietly, invisibly stealing your memory, ranked from commonly overlooked all the way to the most dangerous combination most doctors never warn you about. I'm Dr. Franklin, and this video could be one of the most important 20 minutes you spend this year. One quick thing before we dive in, stay with me all the way to number 1, because number 1 isn't a single medication at all. It's a hidden pattern that affects millions of seniors right now, and almost nobody is talking about it. Let's get into it. Now, I want to be clear about something before we go through this list. I am not telling you to stop your medications. Please do not do that without speaking to your physician. What I am telling you is that you have every right to ask questions, to understand what's going into your body, and to advocate for the health of your brain. Knowledge is not dangerous. Silence is. Also, drop a comment below right now. Tell me, are you over 60? What medications are you currently taking? I personally read through comments and I want to understand what you're dealing with. Your experience might help someone else watching this today. All right, number 9. Medication number 9, diphenhydramine. Here's a question. How many of you have a small bottle of Benadryl in your nightstand right now? I'm guessing it's a lot of you. And I completely understand why. It's cheap. It's over the counter. It says sleep aid right there on the package. What could be more harmless? Here's what that little pink pill is actually doing inside a brain over 60. Diphenhydramine belongs to a drug class called anticholinergics. And that word is going to come up a lot in this video, so remember it. Anticholinergics work by blocking a neurotransmitter called acetylcholine, which is the brain's primary messenger for forming memories, maintaining focus, and staying alert. When you're young, your brain has plenty of acetylcholine to spare. When you're over 60, you're already running on a lower baseline. Block even more of it with a nightly Benadryl, and the impact is significant. A landmark study in the Journal of the American Geriatric Society found that older adults using diphenhydramine regularly faced a substantially elevated risk of cognitive decline, with measurable shrinkage in memory-related brain regions identified in neuroimaging studies. The sneaky part? It hides in dozens of products you don't even think of as antihistamines. Anything labeled PM, nighttime relief, or sleep formula almost certainly contains diphenhydramine. What to do instead? For allergies, ask your doctor about second-generation antihistamines like loratadine, Claritin, or cetirizine, Zyrtec. These don't cross the blood-brain barrier the same way. For sleep, we'll talk about safer alternatives later in this video. Medication number 8, proton pump inhibitors, PPIs. Raise your hand if you've been told you need to take an acid reflux pill every single morning, and you've been doing it for years without anyone ever suggesting you try to stop. This is one of the most overprescribed medication categories in the entire world. And the problem isn't just that people are on them, it's that they're on them indefinitely, when most were designed for 8 to 12 weeks of use. Proton pump inhibitors, or PPIs, reduce stomach acid. That sounds straightforward. The problem is that your stomach acid also serves a critical function. It extracts and absorbs vitamin B12 from your food. B12 is not optional for brain health. It's essential. Deficiency in B12 is clinically linked to memory impairment, depression, nerve damage, and a pattern of cognitive decline that mirrors early Alzheimer's so closely that the two are sometimes confused even by experienced physicians. A 2016 study in JAMA Neurology examined over 73,000 adults, 75 and older, and found that long-term PPI users had a 44% higher risk of developing dementia compared to non-users. But it gets more layered than that. Research has also shown that PPIs may accelerate the accumulation of amyloid beta plaques, the toxic protein buildup that's one of the defining features of Alzheimer's disease. We're not just talking about a B12 deficiency, we're potentially talking about a direct molecular pathway to neurodegeneration. What to do? Talk to your doctor about tapering off PPIs using H2 blockers like famotidine, Pepcid as a bridge. Dietary changes, smaller meals, avoiding late-night eating, elevating the head of your bed slightly, can dramatically reduce reflux symptoms naturally. And if you stay on PPIs long-term for genuine medical need, make sure your B12 and magnesium levels are tested regularly. If you're still here with me and finding this helpful, take a moment to type 8 in the comments. It lets me know you're watching and getting value from this. Medication number 7, bladder control medications. This one genuinely frustrates me, not because of the medication itself, but because of how little patients are told about it. Overactive bladder is a real issue. It's embarrassing, it disrupts sleep, it affects quality of life. And when a doctor hands you a prescription for oxybutynin and tells you it'll help, you take it. Of course you do. What almost nobody explains is this. Oxybutynin is one of the strongest anticholinergic medications in common clinical use. It doesn't just work on your bladder. It crosses the blood-brain barrier with remarkable ease and directly interferes with the same acetylcholine systems responsible for your memory and learning. Studies have shown that the hippocampus, the brain's memory filing center, actually demonstrates measurable volume reduction in long-term anticholinergic users. We're talking about a physical structural change, not just foggy thinking. Brain tissue. A comprehensive 2019 study published in the British Medical Journal found that seniors who use strong anticholinergic medications like oxybutynin for more than 1 year had a 49% higher risk of dementia diagnosis, nearly 1 in 2. Here's what makes this particularly heartbreaking. The early cognitive symptoms, forgetting appointments, misplacing objects, losing words mid-sentence, are almost universally chalked up to just getting older. The medication never gets questioned. The good news, newer bladder medications like mirabegron, mirbitriq, work through an entirely different mechanism, beta-3 adrenergic agonism, and carry dramatically less cognitive risk. If you're on oxybutynin and you've noticed mental changes, please have this specific conversation with your urologist or primary care physician. Medication number 6, benzodiazepines. I want to pause here for a moment because this next category is one that people have very strong feelings about, and understandably so. Benzodiazepines, or benzo, have helped millions of people manage severe anxiety, panic attacks, and sleep disorders. For many people, they felt like a lifeline at a desperately difficult time. I am not dismissing that. What I am asking you to do is hear the science. Benzos work by amplifying a brain chemical called GABA, your natural calm-down signal. They're remarkably effective at producing short-term relief. The problem is what happens when that mechanism stays switched on for months or years. A 2022 study tracking over 8,000 seniors across a 6-year period found that those who used benzodiazepines for more than 3 months had a 51% increased risk of Alzheimer's disease. The risk was highest for long-acting formulations like diazepam, which accumulate in fatty tissues, including brain tissue, over time. Here's the biological explanation. When GABA is chronically over-amplified, your brain starts reducing its own natural activity and response. Neuroplasticity, the brain's ability to form new connections, learn, and adapt, begins to deteriorate. Memory encoding slows, emotional regulation falters. The brain that was being calmed begins to lose its capacity for dynamic response. And the trap? When you try to stop, withdrawal is brutal. Rebound anxiety and insomnia can be far worse than the original symptoms. This makes the drug feel necessary, even as it's causing the problem. Important, never stop benzodiazepines abruptly. This can be medically dangerous. Work with a physician on a slow, supervised taper over weeks or months. Alternatives include buspirone for anxiety, CBTI, cognitive behavioral therapy for insomnia, for sleep, and in some cases, low-dose melatonin or magnesium glycinate. Medication number 5, statins. Now, before I explain this one, I want to be careful because statins genuinely save lives. Cardiovascular disease remains the #1 killer of people over 60, and for many patients, statins are appropriate and important. But here's what your cardiologist may not have told you. Your brain is made up of nearly 60% fat. Cholesterol is not the villain it's been portrayed as in the context of the brain. It's a structural necessity. It forms the myelin sheath, the insulating layer around your nerve fibers that allows signals to travel quickly and efficiently. It's involved in the formation of synapses. Without adequate cholesterol, your neurons struggle to communicate. When you aggressively lower systemic cholesterol with a statin, you risk crossing a threshold where the brain doesn't have what it needs to maintain its architecture. The FDA actually updated statin labeling in 2012 to include warnings about memory loss and confusion as potential side effects, a relatively rare acknowledgement that the agency issued after reviewing thousands of adverse event reports from patients. A 2023 analysis in Frontiers in Aging Neuroscience found that seniors over 70 using high-dose statins for more than 3 consecutive years had a measurable increase in mild cognitive impairment compared to non-users. Here's the important nuance. Not all statins carry equal cognitive risk. Lipophilic statins, like simvastatin and atorvastatin, cross the blood-brain barrier more readily. Hydrophilic statins, like pravastatin and rosuvastatin, have shown significantly less impact on cognition in comparative studies. What to do? If you're on a statin and experiencing brain fog or memory changes, ask your doctor whether switching to a hydrophilic statin might give you cardiovascular protection with less cognitive impact. Also have your CoQ10 levels checked. Statins deplete this compound, which is critical for cellular energy in the brain. If this has been helpful so far, consider sharing this with a friend or loved one who is taking statins. This is something many people simply aren't aware of. And a simple like helps more people find this information. Medication number 4, amitriptyline. This one surprises people every single time because amitriptyline is often prescribed for things that seem completely unrelated to psychiatry. Nerve pain, chronic migraine prevention, fibromyalgia, even insomnia. It's an old tricyclic antidepressant that's been repurposed over the decades for a whole range of conditions. Doctors sometimes choose it specifically because it causes sedation, using that side effect as a feature to help patients sleep. But here's what makes amitriptyline uniquely dangerous for older brains. It is one of the most potently anticholinergic medications still in widespread use. Its affinity for muscarinic receptors, the sites where acetylcholine does its work, is extremely high, higher than many drugs that were specifically developed as bladder medications or allergy treatments. A landmark 2015 study in JAMA Internal Medicine examined over 3,400 adults aged 65 and older over a 10-year period and found that high cumulative anticholinergic exposure, with amitriptyline being among the top contributors, was associated with a 54% greater risk of dementia. And the damage wasn't dose-dependent in the dramatic way people expect. Even low, steady doses over years created significant cumulative burden. What I find most troubling is the invisibility of the damage. There's rarely a dramatic warning sign. There's just a slow, creeping erosion, word-finding difficulties, problems with sequencing, a growing inability to hold complex thoughts that gets attributed to normal aging for years before anyone thinks to look at the medication. Alternatives for nerve pain, duloxetine, Cymbalta, or gabapentin carry far less anticholinergic burden. For sleep, low-dose doxepin in very small amounts has a more favorable receptor profile than amitriptyline. For mood, modern SSRIs like sertraline are significantly safer for aging brains. Medication number 3, antipsychotics. I need you to pay very close attention to this one, because what I'm about to tell you is something that happens every single day in nursing homes, memory care units, and hospitals across this country, and most families never find out. Antipsychotic medications were developed for serious psychiatric conditions, schizophrenia, bipolar disorder with psychosis. They are powerful brain-altering drugs with a significant side effect profile, but today they are routinely prescribed off-label to elderly patients who are simply confused, restless, agitated, or difficult to manage. Not because they have psychosis, because they're inconvenient. I'll say that again. There are seniors in long-term care facilities right now who are being sedated with antipsychotic medications, not for their benefit, but for the convenience of short-staffed caregiving environments. The FDA issued a black box warning about this practice over a decade ago, citing increased risk of death in elderly patients with dementia-related behaviors. And yet the prescriptions continue. Here's the neurological damage. Antipsychotics work primarily by suppressing dopamine, the brain chemical linked to motivation, reward, movement, and executive function. When dopamine is chronically suppressed in an aging brain, the results include flattened emotion, slowed thinking, impaired memory consolidation, and accelerated neurodegeneration. A 2022 study in The Lancet Healthy Longevity, tracking more than 25,000 older adults, found that seniors given antipsychotics for behavioral symptoms were 71% more likely to experience worsening cognitive decline within 12 months, even if they had no prior dementia diagnosis. If you have a loved one in a care facility, or if you yourself are being prescribed quetiapine or risperidone for reasons other than documented psychosis, ask direct questions. Ask why. Ask what the plan is to stop. Ask what non-pharmaceutical behavioral interventions have been tried. You are entitled to those answers. Medication number 2, paroxetine. Here's one that doesn't get nearly enough attention, and it genuinely should. Paroxetine, sold as Paxil, is classified as an SSRI, a selective serotonin reuptake inhibitor, the same family of drugs as Prozac, Zoloft, and Lexapro. And when people hear SSRI, they generally think safer antidepressant, modern, better tolerated than the old medications. That's true for most SSRIs. Paroxetine is the exception. Unlike every other SSRI, paroxetine has significant anticholinergic activity. That one pharmacological quirk separates it entirely from its siblings. While Zoloft and Lexapro leave acetylcholine largely undisturbed, Paxil interferes with it in a way that much more closely resembles the older tricyclic antidepressants. A comprehensive 2021 review in Frontiers in Psychiatry found that elderly patients on paroxetine showed measurable declines in short-term memory and verbal recall within the first year of treatment, declines not observed in patients on other SSRIs at comparable doses. The American Geriatric Society has placed paroxetine on their Beers criteria, an official list of medications considered potentially inappropriate for older adults, specifically because of this cognitive concern. The frustrating part is that paroxetine is often prescribed specifically to older adults for anxiety and depression, the very population it poses the most risk to. The fix is simple in concept. If you're on Paxil and you're over 60, ask your physician whether switching to sertraline, Zoloft, escitalopram, Lexapro, or another SSRI might offer equivalent antidepressant benefit without the anticholinergic cognitive burden. Most patients transition successfully with careful tapering. Medication number 1, anticholinergic polypharmacy. All right, we've made it to number 1, and I told you at the beginning of this video that number 1 wasn't going to be a single medication. I want to explain exactly why, because I think this is the most important thing I'll say in this entire video. Every medication on this list taken alone might cause only mild, barely noticeable cognitive effects in some people. A little more brain fog, a little more forgetfulness, easy to dismiss, easy to attribute to age. But here's what happens in the real world. Seniors don't take one medication. The average American over 65 takes 4 or more prescription medications daily. Many take 6, 8, 10, or more. A combination of prescriptions, over-the-counter drugs, and supplements, often prescribed by multiple different doctors who may not have full visibility into each other's prescriptions. When several of those medications carry anticholinergic properties, they don't just add to each other's effect. Research suggests they can multiply it. A 2022 analysis in Age and Aging tracked over 280,000 older adults and found that those with the highest anticholinergic burden, measured using a validated scoring tool called the Anticholinergic Cognitive Burden Scale, had a 120% increased risk of developing dementia over a 10-year period. Double the normal risk from pills. Pills that most of them had never once been warned about in terms of cognitive risk. Let me walk you through what this looks like in practice. Imagine a 70-year-old woman, let's call her Dorothy. She takes Benadryl PM every night to sleep. She takes oxybutynin for her bladder. She was recently prescribed amitriptyline for nerve pain in her feet. And she takes an over-the-counter heartburn pill every morning. 3 of those 4 are anticholinergic. Each one, according to her separate prescribers, is appropriate and safe. Together, her anticholinergic burden score may be in a range clinically associated with significant dementia risk. And nobody, not one doctor, not one pharmacist, has done the math on her behalf. This is not a hypothetical. This is Dorothy. This is Margaret. This is your neighbor, your mother, your spouse. The medical term for this is polypharmacy, specifically anticholinergic polypharmacy. And it may be the single most underreported driver of dementia-like symptoms in the elderly population today. Now, here's what I want you to hear, and I want you to hear it clearly. Drug-induced cognitive decline is often reversible. I have seen it personally. When the medication burden is identified and systematically reduced under proper medical supervision, many patients experience a remarkable recovery of mental clarity. Memory returns, personality reemerges, the fog lifts. Your brain is not a passive organ. It is adaptive, resilient, and capable of healing when given the conditions to do so. Here is your action plan. 5 concrete steps you can take starting this week. Step 1. Write down every single thing you take. Prescription medications, over-the-counter products, supplements, sleep aids, everything. Don't leave out the PM pain reliever you take occasionally or the allergy pill you've been using for years. Step 2. Look up each item on the Anticholinergic Cognitive Burden (ACB) scale. This is a free, publicly available tool that scores medications by their anticholinergic risk. You can find it online with a simple search. Step 3. Schedule a medication review with your primary care physician. You can use that exact phrase, "I'd like to schedule a medication review to assess my anticholinergic burden." A good physician will not be offended. They'll appreciate the advocacy. Step 4. Ask specifically about deprescribing. This is the intentional, supervised process of tapering off medications that are no longer necessary or that carry unacceptable risk. It is a legitimate and growing field of geriatric medicine. Step 5. If your doctor is dismissive, get a second opinion. You are not being difficult. You are being responsible about your own health. A geriatric pharmacist, yes, that is a specialization that exists, can also perform a comprehensive medication review. Before you go, I want to hear from you. Which of these 9 medications are you or someone you love currently taking? Have you noticed any of these symptoms? Brain fog, memory lapses, personality changes, confusion, and never connected them to a medication? Have you had a doctor dismiss your concerns about cognitive side effects? Tell me in the comments. I read them. This community reads them. And sometimes the most important thing is simply knowing you're not alone, and that what's happening to your mind isn't inevitable. If this video helped you today, please share it. Send it to a family member, post it in a group. The person who most needs to see this probably isn't going to search for it on their own. You might be the reason they find it. I'm Dr. Franklin. Thank you for spending this time with me today. Your brain is worth protecting, and now you have the tools to start. Stay sharp, stay informed, and I'll see you in the next one.